Before a baby is born, their lungs are filled with fluid, not air. Because they don't need to breathe yet, a special blood vessel called the Ductus Arteriosus acts as a bypass valve, steering oxygen-rich blood away from the lungs and straight out to the rest of the body. When a full-term baby takes their first breath, the pressure in their lungs drops. That change in pressure triggers the ductus arteriosus to clamp shut, usually within a few days, allowing normal circulation to take over. But for infants born prematurely, especially those born before 28 weeks of gestation, the ductus lacks the structural maturity to close. It stays wide open, a condition known as a patent ductus arteriosus, or PDA. We are looking at a highly vulnerable patient population. These are infants weighing as little as 700 grams, barely a pound and a half, kept alive in specialized incubators under constant monitoring. The exact vessel that kept the infant alive in the womb immediately becomes a dangerous structural leak in the neonatal intensive care unit. A physician exam at the bedside typically begins with the peripheral pulses. A physician is checking for a bounding quality, which occurs when there is an unusually wide gap between the infant's maximum and minimum blood pressure. This instability often presents visually as a hyperdynamic precordium, where the tiny heart can be seen pounding forcefully against the chest wall as it struggles to move excess volume. This effort produces a distinct sound. Through a stethoscope placed just below the left collarbone, doctors can hear a harsh, continuous noise that resembles the mechanical drone of a running engine. This chart compares normal infant blood pressure parameters to the extreme, widening pulse pressure metrics of a PDA patient. The bounding pulses, the visible heartbeat, and the loud murmur all stem from the heart struggling against this growing pressure instability. When these findings appear together, they confirm that the cardiovascular system has entered a state of complete volume overload. While a PDA can sometimes be linked to genetics, like trisomy 21, the vast majority of cases in premature infants occur because of structural immaturity combined with a natural drop in lung resistance after birth. This diagram illustrates a hemodynamically significant PDA. You can see two distinct loops, the lungs on one side and the body on the other. Instead of staying separated, high-pressure blood from the aorta violently leaks across the bridge, shunting from left to right back into the pulmonary artery. This creates the first major consequence, pulmonary overcirculation. The lungs become completely flooded with excess blood, overwhelming the tiny capillaries. Fluid leaks into the lung tissue, leading to severe respiratory failure. The second consequence is systemic steal. Because so much blood is rushing through the leak into the lungs, fluid is actively siphoned backward away from the descending loop, starving the lower body of crucial blood flow between heartbeats. This reverse flow deprives vital organs of oxygen. It places the infant at extreme risk for renal failure and necrotizing enterocolitis, a condition where the starved bowel tissue begins to die. The infant is dealing with opposing crises simultaneously. They are essentially drowning in their own lungs while starving in their vital organs. In the past, doctors primarily focused on the physical size of the opening in the heart. Today, the focus has shifted entirely to measuring the actual hemodynamic impact, exactly how much blood is being stolen from the system. To do this, physicians rely on echocardiography and color Doppler ultrasound to visualize and quantify the invisible fluid dynamics deep inside the infant's chest. This waveform chart demonstrates a Doppler readout. On one side, we have a normal forward-flowing pulse. On the other, we see the chaotic reverse flow pattern of a significant PDA. The Doppler tracks the precise velocity and direction of the blood, confirming the severity of the pressure gradient. The echocardiogram also reveals if the left atrium and left ventricle have started to dilate. This enlargement proves the heart is actively remodeling itself to handle the massive excess of fluid returning from the flooded lungs. By providing objective proof of both the leak and the heart's strain, modern imaging allows doctors to measure the exact severity of the physiological theft before deciding whether to intervene. This presents clinical teams with a serious dilemma. According to the American Academy of Pediatrics, medical therapies like intravenous ibuprofen or acetaminophen often fail to close the ductus or cause dangerous side effects. But sending every fragile infant to open chest surgery carries immense risk. Traditional surgical ligation requires opening the chest wall to physically tie off the vessel. It involves a massive mechanical footprint, a large surgical team, and an enormous physical toll on a baby that weighs less than a carton of milk. Surgery also risks post-ligation syndrome. When the ductus is abruptly tied off, the left ventricle suddenly loses its low-resistance escape route. This causes a massive spike in pressure, known as afterload, that can induce acute heart failure. To solve this, medical engineers developed a transcatheter alternative called the Amplatzer Piccolo Occluder. It is designed specifically for premature infants weighing as little as 700 grams. Instead of opening the chest, doctors thread a tiny microcatheter up through the infant's groin. A tightly woven wire mesh device smoothly emerges from the catheter and self-expands perfectly inside the ductus, plugging the leak from the inside out. The physiological reset is immediate. The left to right shunt stops, the pulmonary overcirculation resolves, and the systemic blood pressure normalizes. By mastering fluid dynamics with precision microengineering, medicine has found a way to safely restore circulatory balance, giving these highly fragile infants the foundation they need to survive.
If you like this video, give us a thumbs up.